Hi, Sam. Thanks for joining me to talk about plantar fasciitis. I hope everything's going well with you.
Yeah, thanks, Clint. Good to be with you, and hope everything's
Excellent.
going all right with you as well, mate.
It is. So we're talking about plantar fasciitis. I guess that's probably something you see quite a lot as a podiatrist. Is that fair to say?
It is. It is.
Gotcha.
Often we see it. Often we see it a lot anyway, but especially these days, we're seeing it a lot more with the events that we've been through after the pandemic. Lots of people getting back to their normal lives and getting back to sport and things like that. So we're particularly at the moment seeing it a lot more. So it's particularly topical.
Yeah. Okay. I was talking to the other guy from Health Aid, Barry, who you also know,
Mm.
and he was I think, what was he saying yesterday? He'd gone back to tennis after 4 weeks or something, and he was just feeling terrible. But the guy who was playing had been playing like once a week or something like that. So I guess
Yeah.
there's that a reminder of the importance of staying active, because sometimes it's the
Yes,
return that can be the killer, not the
that's it.
yeah. But talking about plantar fasciitis, I guess the first question is, what actually is it?
Well, the plantar fascia itself it's a thick fibrous band of connective tissue that goes between your heel and fans out to your toes on the underside of the foot. So that's what the fascia itself is. It's a connective tissue that doesn't particularly like to stretch either. So it's not like a muscle or a tendon that has that ability to elongate and then come back. So it's specifically when we're talking about plantar fasciitis, the itis suffix is an inflammation of that band of tissue then. So it's an inflammation of the plantar fascia. But that's specifically what plantar fasciitis is. Often these days it's used more as an umbrella term for just pain under the foot, around the heel or the underside of the foot, the arch.
Mm-hmm.
We commonly call it the underside there where the arch is. But it can be a vague or an ambiguous sort of diagnosis sometimes when people come in, they say, I think I've got plantar fasciitis, but it really does encompass a couple of different things that are often correlated and often co-located. So within a few millimeters, that could change the specific diagnosis. But if we think of it as pain under the heel, that's most commonly under the heel and the arch, that's most commonly what we refer to as plantar fasciitis these days.
And is it always the plantar fascia though, even though it might be something different? It's always the
No,
plantar.
no, no.
Right.
It doesn't always have to be the plantar fascia, but
Right.
sometimes it is part of a greater complex of issues. So if you took an image, for example, you might see that there are a number of structures involved, the plantar fascia being one of them.
Mm-hmm.
But people will often say, "Oh, it's plantar fasciitis,"
Gotcha.
but there are a number of things that can be happening there.
Gotcha. So that's
but these days.
Oh, sorry. Go ahead.
No, I was going to say just these days people come in and they lump all of those little things together as plantar fasciitis, but it could be a couple of different things in that area.
So does that mean people need to be cautious about diagnosing it and treatment, or is it, even though it's a number of different things, the treatment's kind of the same anyway?
That's right. Yeah, the treatment is often the same unless you have reason to suspect otherwise.
Yep.
We would sort of go down a very similar pathway, very similar stepped framework.
Gotcha.
Of things. But for example, people come in and will say, "Oh, I've got bone spurs, or I've got plantar fasciitis, or I've got this or that," and often it could be one and the same thing, or it could be a number of things co-located. Like I said, could be sometimes things that are masquerading as plantar fasciitis. So there are other conditions that will mimic the symptoms of plantar fasciitis and give us that sort of same effect as a plantar fascia inflammation. But sometimes, as you just said, it doesn't really change the treatment outcome.
Gotcha.
Or the treatment approach. Sorry.
Right.
And so unless we have reasoning clinically to suspect otherwise, we could go along that same sort of pathway.
Gotcha. So that's okay. So that's an interesting piece of information, that when people say plantar fasciitis, it might be any of a number of things, but you shouldn't stress too much if it's not exactly the same thing, because the treatment's probably going to be the same.
A similar pathway, and then obviously that will come down to a clinician, the clinical reasoning and clinical fact finding, and through questioning and tailoring that approach to the individual as to where we would swap and change out of that sort of stepped framework that we would use. Yeah.
So, all right. So that probably makes, I guess, what I'm about to ask a little bit more convoluted, given that it is possibly one of a number of things. what does actually cause it? Like, how does it start in the first place?
Oh, typically, it's we think of plantar fasciitis as an overuse injury, and so the overuse injury means that there's a load that's overwhelmed the structure that we're talking about. In this case, the plantar fascia. Mm-hmm. And when I was saying earlier that it could be a number of things, there are a number of things within plantar fasciitis itself. So we call it plantar fasciitis, but as you may have heard, it can be termed plantar fasciitis, plantar fasciosis, plantar fasciopathy, things like that. You can have heel spur syndrome, bone bruising, things like that are all very, very closely related. But without going into too much detail of them and of each of them and getting imaging to go into it, if we just think of that as that pain on the underside of the heel, all in that same sort of area, the heel and the arch, then yes, we would typically think of it primarily as a mechanical or as a biomechanical issue. Mm-hmm. Where in most cases it's been loaded beyond its means to recover and beyond its capacity to accept that load. So there are certain conditions, like I said, that can masquerade as plantar fasciitis. Mm-hmm. But if we eliminate those for the moment and just think of it as a mechanical condition, it's typically a discrepancy between the amount of load that's being subjected to the plantar fascia and its then capacity or ability to handle that load. So as we were just saying before about Barry, going back to sport after you've had a period of not being active, or, for example, we see that quite commonly after pre-season training, after returning to pre-season training, people have had often a sedentary period for a few weeks. They've been off their feet. Mm-hmm. All of a sudden, they've gone back to activity. That would increase that load through the plantar fascia. Also, things like changing jobs, for example, changing shoes, changing the surfaces we're training on, changes the intensity of our training, the frequency, the duration of our training. So all of a sudden ramping up that load, weight gain can even do that sometimes. Mm-hmm. So that's the two parts to that equation. There's the increasing the load, and then there's the how much can the actual tissue itself or the plantar fascia handle of that load. So we look at it in both ways. What causes it is an overuse, but overuse doesn't necessarily mean that I've done too much. It can just mean I've decreased the capacity to handle that. And that can happen with injury, that can happen with age, that can happen with being off our feet for a while. So that sedentary lifestyle we're talking about, as we age, we might do less. Mm-hmm. So
when you say overuse, is that like just a one-off load, or is it kind of like fatigue theory, I guess? Like if it's a lower load but it's applied frequently, is that equivalent to applying a greater load just once?
Yeah, so it can be. Typically, we if we think about the load being introduced gradually, as you were talking about with the fatigue theory, that would obviously then decrease the capacity of that tissue to handle that load for subsequent loading. Loading would be a bit. So that's where I was saying that part of the equation where we're lessening the capacity of the tissue to handle the load, that would come into play there. Right. So it certainly can be incremental loading over a period of time, where we typically see, that's a gradual onset. And then there are, as you also said, it can be a one-time application of load, and that would be more of a traumatic sort of an injury where we would, all of a sudden get a rapid onset or a sudden onset. And sometimes that can be associated with even tearing of the fascia, if it overwhelmed it that far. It's the same sort of theory, Clint, as we see in stress fractures, where you can get stress fractures that occur because we're incrementally loading. And then we gradually creep up to the threshold of where the tissue can handle it, like in that case, a bone, and then it would fracture. Compared to a traumatic loading, so just a sporting injury where you fell and you broke a bone, and all of that load was applied in one go, and there was a quick onset.
Right. So somebody could be doing something right now, they feel fine, but they're actually slowly and incrementally damaging or doing causing some kind of injury to the plantar fascia, which could be and fasciitis.
Yeah, and that would happen in two ways. So the two varieties of that equation. One is that they're incrementally loading without resting enough for the fascia to be able to handle more load. So they're decreasing the available capacity to handle that load for the next time that they load it. And the other part of it is obviously that they're just doing too much too soon. Anyway, they're overloading.
Right. So essentially, long story short, you've overloaded the plantar fascia, and that's caused the inflammation.
Yes.
It's a fairly simple
in whichever way that is. Yeah.
Gotcha.
Yeah.
So you're saying earlier about using imaging to diagnose it, and we're talking about how it can sometimes be different kinds of things. If you do go see a doctor or a podiatrist or something like that, and they tell you that you have plantar fasciitis, but they haven't taken you, like there's been no imaging done or anything like that, should you be a little bit dubious? Like, should you say, no, I want some kind of an ultrasound or something like that to confirm that it is plantar fasciitis?
That's an interesting one. I typically in my practice don't use imaging as a standalone or as a first port of call unless there's reason to suspect something more than I'm thinking through my clinical history taking or reasoning. As I was saying before, it's something that responds quite well to a stepped framework or a framework that we sort of go by. And if we're seeing that the patient is responding to that sort of treatment program, then there's no reason to suspect otherwise, and we don't usually go down the imaging pathway. However, there are times when, like I said before, you suspect conditions that might be masquerading as plantar fasciitis, or you might want to clarify your diagnosis before going down a pathway. That's the only time I think we would get the imaging. I think we can get lost a little bit in, especially these days with imaging being available readily and the sensitivity of the things like MRIs and ultrasounds these days will pick up many different things. So we'll sometimes, if a patient comes to me with an X-ray or an ultrasound report or the scans, and they'll say, well, I've got this and this and this and this, and they might actually have all of those things, but clinically they might not all be relevant, and they might not be, that might not be the driving factor that's causing their pain or causing the issue that we're seeing. So sometimes we can get lost in a bit of the detail there. Right. And that's what I'm saying. I wouldn't necessarily be too dubious, but we would definitely use imaging as maybe a second line or a third line informative study if we needed to.
So when you say need to, that's like, so chances are it's plantar fasciitis, you know what to do to treat it, you implement the treatment, but maybe it's not happening, you're not getting the recovery that's expected. Think, hang on, maybe now's the time to do some kind of imaging to see what's going on. Gotcha. Yeah,
that's one of the things. Or if it was the history taking just didn't match up, So we're saying that usually, so we're saying there has to be an overuse of some, we have to have overloaded the structure somehow for us to get that pain, if it's consistent with the theory that we're going with. Yep. So if you came in, for example, and you said, no, I haven't actually done anything differently, and there is no particular reason that I can put down to the pain. I might be actually provoking, clinically provoking the plantar fascia. So, palpating it clinically, saying, well, this should be sore, but you're saying it's not sore, but it is sore when you're doing this particular activity. If it doesn't sort of match up with what we're thinking, then I might go down that pathway to clarify the diagnosis, for example, before we subject the patient to a treatment plan. Also, sometimes you do it for, if we view the patient more holistically, and they're particularly worried about it, and they want the peace of mind of seeing what the diagnosis. So sometimes we can use it that way, but not primarily if it's a clinical decision making a tool.
So as a patient, you shouldn't be too worried about whether they've done imaging or not. You should be more concerned about whether the person you're seeing has done a thorough job of just understanding the background and what could have brought you to this situation. As long as they've seemed to have shown enough interest in what you've done and how this could have come about, that's the more important thing than the imaging.
Absolutely. I think it always has to make sense, I think, is the main reason, and sometimes it's not always the case, and sometimes it's a very loosely related thing, like, for example, I just changed my shoes. I went from this particular shoe to that particular shoe. The shoe might be stiffer than the other one. Might be a high top to a low top, might be a certain activity, the job changed, I took out more hours at my job, or anything like that. I started taking the train to work rather than drive, things like that. As long as it might be a loose association, but as long as we can make it make sense enough for us to take that next step in the treatment plan, I think that's the main thing that I'd be concerned with, rather than having an absolute image. As I said, you can have a number of things that will be pointed out by a scan that might not necessarily dictate the severity of the pain that the patient is feeling. So we can jump at many red herrings in that sort of scenario, or take the patient down a journey that they don't really need to go down, because often we plantar fasciitis can be quite debilitating for some people, and it can cause them to then walk differently and adapt to their mechanics, the changes to their mechanics a bit differently, and cause many compensatory patterns. And then that will also reflect on their ultrasounds or their scans.
Gotcha.
But that's not where we should be primarily treating our patient. We should be saying, okay, well, I can see how this would happen as a result of what we're talking about, but I still think the value is in treating what we're talking about rather than looking at X, Y, and Z first.
So just to summarize, like sometimes a scan might reveal a number of issues, but those issues are actually a knock-on effect from the original plantar fasciitis. But when you just look at the image by itself, you can't necessarily tell which one's caused by what. But it's not until you look at the history when you say, well, actually, then you can create, I guess, like a timeline of how these things would happen.
Absolutely,
it's very interesting.
Yep.
Now, I was going to say, speaking of treatment, how it can be very debilitating for some people, and they walk differently and things like that. How do you actually treat it? And does that treatment, I guess, involve just basically not walking anymore?
No, well, it shouldn't involve not walking anymore.
Okay.
I think that is one of the misconceptions, that people say, well, I've got to stop doing this and I've got to be off my feet for this period, or, it happened because I was training, so I've stopped training. And they've often come in to see somebody after a period of self-treatment, let's say, where they've just withdrawn from activity and things like that. And so, but if we go back to what we said earlier about the equation that we were talking about, where we said overuse was a load increase and then the capacity of the tissue to handle that load. So I think we would usually have a step approach, which was initially about load management, so reducing that load, and also about building capacity in the tissue itself to handle that load. And so that doesn't mean load management when we're saying reducing the load or managing the load. That's reducing the physical stress on the tissue. But we don't usually like to say that would mean that you're off your feet or you're not doing anything like that. But it could be things like changing the intensity of the activity, changing the frequency of the duration of the physical activity, and then increasing capacity or building the capacity of the fascia to handle that load, which would be things like our stretching and our strengthening exercises. Although that's not for everybody, but things like that to increase the capacity and introduce some walking. I'll give you an example for if we took somebody who has been sedentary for quite a while, not actually on their feet for a long time, they've withdrawn from activity, they've come in to see someone after a year or so, and they've had a period where they've just not been walking. Now, the capacity of the tissue to handle activity will be very low. So usually that means as soon as they go out for a walk, they're not able to handle that load, and they'll just withdraw again, and we'll have that sort of lessening of capacity again. In that case, we would focus the treatment on, yes, we want to treat the symptoms as well and look at the mechanics of that, but we want to introduce some load capacity increases there. So getting them to start walking, to start weight bearing, and building that capacity of the tissue again. On the other hand, if we're not concentrating on building the capacity, we treat it with things like, we look at it primarily through a mechanical lens. So that's the mechanics of the foot posture, the way their foot accepts forces and loads forces, things like the shoes they're wearing is quite important. The surfaces that they're training on, and like I said before, the amount that they're doing, the amount of their training and running and walking. But I tend to use orthotics quite early in the piece, and strapping and orthotics, which is a mechanical therapy. It doesn't always necessarily have to be a prescribed or a customized orthotic, but it can be something to correct the forces going through the fascia and make their walking and training more efficient, so that we're still able to keep them walking. So going back to the point about not telling them to stop walking or running, still enabling them to do what they want to do, but doing it in a smarter way, or in a way that is allowing that fascia not to be overloaded.
So the treatment, so if I've understood that correctly, the main aspect of the treatment is to correct the way the foot is used, or the way the foot moves, so that the forces go in the correct direction And
yes,
the
that's
plantar
from a
fascia
mechanical
isn't
perspective.
Gotcha.
Yep.
So
Yeah, so
go ahead.
I was going to say, so that might involve things like, heel raises, orthotic exchange of footwear, things like that. That in some cases, even periods of immobilization, like through like a little cam boot or something like that, where, depending on where we're seeing the patient and depending on how severe it is and what their activity is, looking at it from a holistic point of view, obviously we need to take into account what they're doing, how they're doing it, and tailor our approach that way. But from a mechanical perspective, we definitely want to do things like that. We know that ankle range of motion is correlated to plantar fasciitis, so we might incorporate things like calf stretching, heel raises, things like that.
Oh, okay.
From the mechanical perspective.
So when you talk about range of ankle movement, is that primarily related to flexibility in the calf?
Yes. Really?
Yeah. Okay.
Yeah, primarily that. So that's related to it, and often changes in shoes, which will incorporate that for us as well, and changes we can often add things to shoes. So that's where I look at it from a mechanical perspective as my initial therapy, or I bring that in quite early. A lot of GPs, for example, or a lot of people will come in saying that GPs have offered them a cortisone injection, as the first line of treatment. I look at it the other way around. I try and correct things from a mechanical point of view, first of all, so that, because we take a few thousand steps a day, depending on what we're doing, between 5,000 and 15 or 20,000 steps a day, some people will take. And so if we can correct or make the foot move in a way that is limiting the forces through that fascia, the ground reaction forces through that fascia, with every step, then we're going a long way to making sure we've got that active recovery. Gotcha. On the other hand, we're doing things that's trying to heal the fascia or increase the capacity of the fascia. I think that hand in hand, over a period of time, will elicit the response that we want to in most people. Yep. Now, that's for the treatment side of the causative factors. The other side of it is, like we said before, we've got to think about the patient's well-being in general, and their, if we're looking at it from a biopsychosocial model, we're looking at it in terms of, well-being, depression, anxiety, things like that can come with people not being able to do what they want to do and not being able to stand for long periods and things like that. So we do sometimes, in terms of treatment, often use therapies that would try and increase that healing capacity or trying to stimulate that healing capacity. Things like shockwave therapy, things like, sometimes even people, we would use injection therapy, so PRP injections rather than cortisone. PRP? Which is the PRP is platelet-rich plasma, so it's platelet-rich plasma injections. So that's trying to stimulate the healing capacity of the individual. It's not for everybody, and we don't do that. We don't offer that to everybody. But like I said, we've got to know how the patient is responding to our initial treatment plan, how quickly they're responding, how quickly their body is responding to that, and whether it's important for them to, for example, if they were trying to get back to sport really quickly because it was they were getting paid to do that, for example, and it was quite important for them to be back as quickly as they could, or they were going on a holiday, and that was really going to impact their ability to socialize with their friends or their families and that sort of thing. So we do have things in the clinic that we could use to speed that up, but everybody's a little bit different. But they all start with the main thing is trying to load manage the structure and trying to increase that capacity. So
gotcha. You're talking about shoes there.
Yep.
How frequent, and this might be something you need to take a guess at, but how frequent do you think the issue of plantar fasciitis would be if we just didn't wear shoes?
If we didn't, I think that would depend on who it is. Right, I think it would depend on, and I say that from experience based on the period of time when barefoot running exploded. We had a lot of people that would read about barefoot running or talk to their friends about barefoot running and join that sort of craze at the time. Now, some people would be perfectly fine doing that because the mechanics are okay, and the activity that they chose to do on the surfaces that they chose to do it meant that they weren't overloaded. I think it all comes back to that. Being engineers, we can understand that it all comes back to the loading, so it all comes back to how quickly you're loading and how efficient you are at dealing with that load. So some people, for example, with a an inability to handle much force.
Mm-hmm.
If you've gone, if we're not wearing shoes and you've introduced a lot of running or a lot of activity, that's then introducing a lot of force and then therefore stress through the structure. Mm-hmm. They would break down pretty quickly. They would see symptoms pretty quickly, and we actually did see that with not only plantar fasciitis, that was very commonly seen. Mm-hmm. Traditionally people say it's related to flat feet or pronating feet. It's not necessarily always the case, but it can be seen with a lot of people with flat feet. Yes. But in that sort of scenario, we would see a lot of people break down.
Right.
And we had a lot of people with stress fractures at that time and fasciitis.
So it's not just simply it's all the fault of shoes. It's the nature of, I guess, the way the individual's body works, and also the surfaces, what they're doing in the surfaces that they're doing it on. So there's a few contributing factors there. Gotcha. Okay.
It's a multifactorial thing, and it's a very complex thing which will take it. I mean, it also. I did some research about 10 years ago it was a qualitative research into how overuse injuries affected people, and looking at the footwear side of things, and whether a cushion shoe is better or not, or a stable shoe is better or not. But I found even at the time, looking at the literature, even things like sleep and diet and stress levels would affect a person's ability to heal and a person's ability to handle those forces and what injuries they get. So I guess that's a big way of saying that it's a very multifactorial condition. Not only plantar fasciitis, many conditions are the same sort of thing. So it'd be very hard to say, okay, well, it's just the cause of it. This particular factor is the cause of your pain. And that's why I'm saying we need to view the patient in that lens where we say, okay, well, this is the sort of approach that I would take in general, but through my, heuristics and clinical decision-making and experience of the practitioner, you'd be able to say, well, I think I need to move this part earlier, or I need to put this part later, and just see what's going to work best for that patient.
Gotcha. Understood. Yeah, okay. That's good to know. Because I guess there are probably some people out there looking for that silver bullet solution, which might be if I just don't wear bad shoes, or if I just don't do this one thing. But there's so many things that can contribute to it that it's something that anybody could end up getting at some stage, and you're probably going to have to go through the treatment process.
Yeah, and absolutely, shoes. That's not to downplay the role of shoes.
No, understood.
In the treatment, it is important, and often a change of shoes is important. For example, going from one end of the spectrum, a very cushioned shoe, to a very rigid or stable shoe, and doing the same level of activity, that will be a stimulus for pain as well. So,
gotcha.
I think it's got to be looked at in terms of the patients. In that case, in very simplistic terms, people are looking at their foot type and saying, well, if I was wearing the wrong shoe for the wrong activity, then that would be a bad thing. Running in a business shoe, for example, or a dressy shoe would be an obvious one. It's or people walking an hour to work in their dress shoes on concrete, or if I look at an example that I've seen recently where parking inspectors, they're wearing business shoes, but their job primarily is walking in car parks on hard floors, and so those sorts of things where that's an obvious one. The shoe would be the first thing I'd be looking at in that sort of scenario. Whereas somebody who's wearing joggers and running, or Barry playing tennis or something like that in his tennis shoes, the shoe might not be the first thing I'd be looking at in Barry's scenario.
Yep. Okay. So the treatment is kind of understanding the situation you're in, and through some informed decision making, trying corrections that should eliminate what's inducing the plantar fasciitis in the first place.
Absolutely.
And also some kind of exercise to make the body more robust against plantar fasciitis.
Yeah, and that's often stretching. That's often calf stretching and plantar fascial stretching and things like that.
Yeah, I was going to say, there's no harm in getting a bit of flexibility in your calves regardless. So if anybody out there is worried about just some calf stretching, is probably a good thing to do regardless.
Absolutely.
Yep. How long does it typically take to get over plantar fasciitis?
That's a tough one as well to sort of say for everybody. But typically I would say, unless it's been there for years, or, it's become a quite chronic condition. Sometimes if it's chronic, it can take a little bit longer to sort of to make the gains that we expect. But in most cases, I work to about a 6 to 12 week window. Gotcha. When I should start seeing results. And when I say 6 to 12 weeks, I don't mean that at 6 weeks it sort of snaps off and the pain's gone. it's usually a downward trend. So we're improving. And I guess that's another important thing. How we know that it's going well is making sure that the person can do more, or do more often, or do more with less pain. Doesn't necessarily mean that the pain's gone, because they're still working on it every day. It's interesting with the fascia and things like the underside of the foot. If you're still loading the structure, because you are doing, like we said, 6,000, 20,000 steps a day, if you're still loading that tissue, you're still going to expect that it still has to be under some sort of stress, right? So what we're not doing is like hurting our shoulder and putting it in a sling and saying, well, that's not moving for 6 weeks. So we still want the person to walk, and so that's why we use it as we use the 6 to 12 week as a guide. And I like to sort of make sure that we're seeing, if we take a 6 week block, for example, and split it into 3 2-week blocks, I like to make sure that each subsequent 2-week block is better than the one before in a net effect. But yeah.
So you're going to say
that's 6 to 12 weeks.
Gotcha. And so, but also though, for anybody out there who's going through treatment or is treating somebody else, I mean, I wouldn't say instantly, but like you said, within 2 weeks or so, there should be some evidence that things are getting better.
Yes.
Right.
Yeah.
So you should,
and that.
Go ahead.
Sorry, I was going to say, and that evidence doesn't necessarily have to be pain.
Right.
Yeah. So pain is not always representative of the pain isn't representative of the state of the tissue, for example. So the as I was saying earlier, the way we look at it is, if you're in the same amount of pain but you're able to do more, that's a bit of a win. That's an improvement.
Gotcha.
Because you could. What I always tell my patients is that I don't like them coming in and saying, "Oh yeah, it might feel better," but I've actually stopped doing what I want to be doing. So I stopped in Barry's example Barry's case, for example. I wouldn't want him coming back and saying, "Yeah, the pain's gone, but I don't play tennis anymore." That's a sort of a false positive there.
Yep.
If he was able to play tennis and the pain was still there, but it was less intense, that would be great. If it was less frequent, that would be great. So in that case, we're looking at the overall.
Understood.
So
there should be there should be some measure of improvement.
Yes. Yeah. I look at more in terms of function rather than pain. So you can do more, you can do it for longer, it stays better for longer, it's not a sore in the morning, for example, that sort of thing. And then the next sort of week or the 2 week or whatever metric you're looking at, it's a bit better again, and then it's a bit better again. That way, two things from that. That the intervention that you've put in place, or the interventions that you've put in place, are working. And you also know the rate that your body is healing at naturally. So if you said, for example, that it is getting better, but it's getting better really slowly, that's when we look at, if we return earlier to the talk, what we were talking about earlier with the shockwave, for example, and the PRP, we can say, it is getting better with our mechanical interventions, but it's not actually doing what we wanted to do. Is, I'm not comfortable with the rate that we're going at. So let's try and kickstart that process with an external stimulus. Or you can say, it is getting better. It is getting better at a rate that I'm comfortable with. And I'm being the patient here, not the clinician. I guess it's what the patient's comfortable with. And then that way you don't need any other interventions. The intervention you're making is work. The opposite of that is also true. If you've put in an intervention and within a few weeks it's not actually doing anything, it's very unlikely that if you left it for another period of 3 weeks or 4 weeks, all of a sudden it is going to do something. So we should always be measuring. So you have some metric to measure against and say that I'm putting in this intervention. I've changed my shoes, for example, but within a few weeks it's made no difference. So I should be looking at something else, or going to see somebody, or whatever the case is. And primarily I look at, like I said, function rather than just pain. So if I can do more, for longer, if I can stay, have more good days than bad days, that would be great. And if then I look at a couple of periods in a row and I can compare those back, I'll be able to say that, this period is better than that period is better than that period. Therefore, I know that, there is a downward sort of a trend to my pain. So that's good.
Brilliant. Thank you for that, Sam. I think that was a pretty good rundown. Now also, I should sort of ask you, you do actually have your own online business selling a number of foot-related products. Is that correct?
I do. Yes. Yeah.
Tell us a bit about what you have and how people can find it.
Beautiful. In terms of, I'm involved with two of the online sort of sites. One is primarily involved with orthotics and insoles and things like that, braces, splints, orthotics. So that's at myorthotics.com.au. You can find that there, and that would have a range of insoles that people can refer to and put in their shoes. That comes down to that mechanical sort of treatment that we were talking about, where we don't quite need to go to a custom level orthotic and spend a lot of money to start with for everybody. We can often get away with using some other orthotic intervention to be able to modulate those forces, and so that they're primarily ready to go, ready-made insoles that people can try there. And then the other one is, which is probably a bit more relevant to the plantar fasciitis talk itself, which would be painpacks.com.au. Painpacks is basically it's a collection of products that you would need to deal with certain injuries or certain ailments. So in terms of plantar fasciitis, there would be a plantar fasciitis box, and that box will have things that you need, like an ice pack, for example, some strapping tape. You would have things that we typically use in clinic for treating these conditions, and it would come with instructions and a program to sort of, if people weren't looking to go and buy everything themselves and looking up things on the internet themselves, or going to see someone, they were looking to inform themselves of how to fix the problem, or try initially to fix the problem. This would give them everything they needed to try and do that, in a program to follow along with, and importantly, something to measure as well. So something to measure with. Yeah, excellent. As I was saying before, we need to make sure that they are going the right way, and if they're not, then refer on, and being able to then go and see somebody who could maybe find a missing piece of the puzzle that might just be stopping their body healing.
Gotcha. So that was it painpacks.com.au and myorthotics.com.au?
Yes.
Excellent.
That's it.
Thanks for that, Sam.
Appreciate it. No worries.